Ready to go. We're recording and all set.
Okay, so I'm going to do the introduction now. So welcome back, everybody. So our next speaker, and it's great to have Indira Paul Singh with us. He really has become a superstar in the area of glaucoma surgery and new surgical developments. Dr. Singh is a Wisconsin native and is the president of the Eye Centers of Racine and Kenosha that was founded 40 years ago by his father. He was a chief resident and has completed his residency at Cook County Hospital, the Department of Medicine in Chicago, and graduated from Finch University, of Health Sciences, the Chicago Medical School. He completed his fellowship in glaucoma at Duke. So through, I don't want to, keep going throughout Dr. Singh's bio. I mean, he was instrumental in bringing laser-assisted cataract surgery into his area. He's been named one of the best eye doctors in the United States. And for our purposes, most importantly, that he really has been on the forefront of the development of the new trends in terms of interventional glaucoma. So with that, it's great to have Dr. Singh with us, and let me turn the program now over to Dr. Singh. All yours.
Thank you, Murray. Thanks for that great introduction as well. I love your background. You in downtown right now?
So in Chicago, right this second.
It looks nice. Yeah, I love that backdrop. It's wonderful.
Yeah,
well,
so
well first of all,
I'm in Chicago in a hotel room. So anyway, all yours.
It looks nice. Yeah. Okay. Back to me. Well, thank you for the opportunity to present, and hopefully we'll keep this interactive. Please feel free to share your thoughts and comments, and text away or kind of do the chat room function. But I appreciate the opportunity. I love educating. I love learning. I learn from everybody I meet. I think we all can learn that there's no right or wrong answer in glaucoma, and that's what we're trying to figure out now, and why there's so many options that we have, because we realize there's no perfect surgery, no perfect drug, and we're all still trying to figure it out as well. So today I thought I'd focus in the next hour and a half, hour and 45 minutes or so on really what's happening with this interventional mindset. It's this new paradigm shift that we're seeing in glaucoma, where we're really starting to intervene earlier. And what does that mean by intervene? It could be laser, it could be drug delivery, it could be MIGS, it could be just even new molecules, and understanding what is really truly maximum tolerated medical therapy. And that definition, as we'll talk about, has really morphed since I've been out of fellowship for the last 15, 16 years as well. So we're going to go through some different technologies, and then probably slow down and speed up depending on kind of where we're at in terms of time. But I do speak and consult for a number of the companies in the glaucoma and anterior segment space. I call myself like a confused glaucoma guy because I do a lot of also anterior segment, refractive surgery, cataract, etc. But a lot of glaucoma still is my passion. And I am from Wisconsin, as Mary mentioned, southeast Wisconsin. It's a cheese head that actually does fit over my turban. My parents, when I went to school at WashU undergrad, they gave me a box and said, "Son, when we leave, please make sure you remember your roots and open this box." And so I thought they'd have like an Indian Bible or a turban or something, but no, they actually made a cheese head that fit over my turban, so I never forget my roots as a Wisconsin native as well. So if you ever come to Wisconsin, we love our beer, we love our cheese, we love our football. Sorry, we love our Packers, although we did not so good this first week of NFL, but we love to deep fry everything. So if you ever want to come to a state fair, you'll find deep fried everything you can possibly imagine. That's Wisconsin for you. I do have 3 kids. I think kids are the biggest equalizers of life. You've had the best day in the world. You think you're the best doctor. Patients are happy with you. You think, I rock. And you come home and your kids go, "No, you're not, Dad." They bring it back down to earth. But then on the other hand, when you have a horrible day and like everybody sucks and you're like, your patients aren't doing well, and you're like, "I suck at it as a doctor." You come home and they're like, "Papa, we love you." And you're like, "Oh." So they're my 3 kids. This is from many, many years ago. They're now grown up, unfortunately. And they're very honest with you. And this is where they gave me my birthday present last year during COVID. And it was like the quote on my daughter's painting was, "My diet starts tomorrow." That was my basically mantra throughout all of COVID. So gained a lot of weight. today. Thankfully, we have Zoom here, so you can't see my whole body. But back to glaucoma, I really think that is a fun, exciting time for us right now. We have a number of various options for our patients to tailor, to earlier intervene, as you guys have known with all our MIGS discussions over the last 5-6 years. But it really is a toolbox, right? Whether it's laser trabeculoplasty, I think as we'll talk about the LIGHT study, we're seeing a lot more data coming out and the kind of impact of earlier adoption of laser trabeculoplasty, get them off of drops, whether it's MIGS or even drug delivery now, which we'll talk more about as well. We have a number of options, and even new molecules like latanoprost and Bunod, Ryzolta, or Natarsadil, and even what that kind of how that interacts with some of these earlier kind of adoption of understanding pathophysiology. Can we earlier address the pathophysiology of glaucoma, address the outflow right away? Can we change the morphology, the natural progression of glaucoma with utilizing a number of these technologies? And I always joke around. I would say, obviously glaucoma is going through a lot of changes. When I first started out, actually, when I was a fellow, I got made fun of at Duke as a fellow. They're like, all these cornea and retina colleagues were like, dude, why would you go into glaucoma? It's so lame. No one ever gets better. All you do is punch holes in people's eyes or put them on drops and make them miserable. And then MIGS came around and all these other cool technologies. I had a reunion. They're like, hey, you're kind of cool now. I feel like this guy, where like people want to talk to me now. Hey, come hang out with us. Come give us a lecture. It's like, see, I knew one day we'd have that opportunity. But the impetus, what's causing all this explosion? Why are we seeing this incredible proliferation of technology? Truly because of compliance. And you guys know this better than anybody, right? We see compliance issues all the time. It really sucks. And I think that we've seen it every day in our practices, whether it's, side effects of drops, or it's adverse events from, the redness of the medication, or even the physical attributes, people are having a hard time taking meds. And what they'll do, I always joke, if you ever want to have some fun, if you're bored in your office, give a patient an artificial tear and see what happens. It's amazing what they'll go through to get drops in their eyes. And you guys, I'm sure, have seen all that way too often. And just to remind us all, and this is all obvious stuff here, but very few percentage of our drops get in the eye. In fact, 5% really total volume and total actual drug gets into the anterior chamber because of the barriers to comply of our cornea and our conjunctiva, the lacrimal system washing it out. Very little time. So the only way to get more drug is increased concentration or increased residence time on the surface of the eye. So vehicles as well, which is what a lot of the drops do. But again, that can also cause more irritation to the eye as well. And so because of all that, I've now redefined what is considered controlled glaucoma. For me now, the definition in my chart is not just IOP is stable, visual fields are stable, optic nerve is stable, which is of course the crux and the most important issues. But I also now include this quality of life. This part of my equation of controlled glaucoma is now as important, because if I have a patient like that on the right where their eyes are crusting and red and they're having a hard time taking medications, yeah, they may be controlled at today or even next year, but it's just a matter of time. They're not going to be stable with their current regimen. They're going to fluctuate and problems are going to occur over time. So I recognize that now in my chart, and then I address it with the patient. Say, look, you're having a hard time. Let's not wait till you have significant field loss where your target pressures are lower, right? Because I always joke to my docs, we say, well, a lot of these SLTs and drug delivery and even certain MIGs don't have the power to, like a trabeculectomy, right? So I'm not going to really do those surgeries. Well, if we're waiting until people are so advanced with the target pressures 10, 12 range or below, then yeah, those conventional MIGS procedures aren't going to work well. But if your target pressure is 15, 16, or even upper teens in an earlier glaucoma patient, a lot of these newer adoption of these newer interventions can work well and prevent further progression over time. So my new paradigm shift of kind of where my new treatment modalities and kind of my new progression is now really SLT first line for majority of my patients. If they're open angle and they're a good candidate for SLT, which is majority of my patients, I offer it at least. I don't say they have to have it, of course, but I offer it. And then I will very quickly go to a MIGS procedure. Canaloplasty we'll talk about. Oops, sorry, the light went off here in my hotel area. 1 second, guys. There we go. So it's this auto lighting thing here, this hotel I'm at. So basically, I'll tell patients, okay, we'll do laser. If not, we can do an earlier MIGS, like a canaloplasty or one of these other procedures we'll talk about. I'll go back to doing more laser or even a subconj MIGS, like a Zen, and then eventually do my trabs and tubes if I need to. So they're really pushed way, way down where I've tried everything else, so to speak. But drops are still needed. Doesn't mean drops are bad, but we still need them drops, but they're throughout the whole course. It's not drops first and then everything else. It's drops are there to save me as needed as well, or even drug delivery is needed. So I'm going to talk a little bit about first-line SLT and why I'm a big fan of this idea, because I do think it has some options and some benefits to first line. We all realize that, as you know, trabecular meshwork is a site of resistance for majority of our patients, whether it's TM or even juxtacanalicular tissue as well. And so my thought is, if we can actually address the actual pathology early on, do we have the potential to change the actual progression, the natural progression of disease? Because think about aqueous suppressants for so long, right? Timolol, carbonic anhydrase inhibitors. What that does is decreases flow. By decreasing flow, what's happening is you're getting more collapse theoretically of the TM, which then has more collapse of the Schlemm's canal behind it, and then more atrophy of the distal channels, a vicious cycle. So that's why after years and years and years of people on drops, especially aqueous suppressants, their conventional pathway may not be as healthy enough to even have a good outcome with one of those conventional pathway MIGS procedures. So the thought is if I can earlier address the pathology, get that flow through the TM, can I actually then allow the canal to stay more patent as well as the distal channels? That's the kind of theory behind it. And of course, we've had ALT for many years. And SLT, I think, just to reiterate the fact that it doesn't cause significant fibrosis or scarring of the angle is important, because now with MIGS, it is important because, you know, if you're going to do ALT a lot and cause scarring, you may have a hard time with your canaloplasty trying to open up, or even one of those stents like a hydrus trying to scaffold some of that canal. If you're having some fibrosis from ALT, you may have a hard time. So SLT does not prohibit us or have any restrictions rather from pursuing a conventional pathway MIGS procedure later on, which I think is great. And then because it does rejuvenate, I always tell my patients, this is a rejuvenation procedure, right? I always tell my patients, the way I present it to my patients, it's not a laser. I always say, Mr. Smith, your eye's a water balloon, and the eye fluid, the water balloon's getting tighter and tighter because the fluid the eye makes is not leaving to the drain inside the eye. So what we're gonna do is use a beam of light that excites or stimulates your own drain to release your own enzymes to open the pores naturally, to rejuvenate it. That's my spiel to them. It takes about a minute or so in the office. There's no injections or patches. It's covered by insurance, and you get to go home without any restrictions. That spiel within 10, 15 seconds, most patients are like, oh yeah, sure, doc. And I always tell them, look, if we have to go back on drops or add or start drops, we can always do that if we have to. But the fact that it's kind of a rejuvenation, I actually like that idea. And so for me, there's no doubt there's efficacy data we'll show you and talk about, but I think the diagnostic potential, and here's what I'm going to talk a little about as well, which is kind of novel, is this idea of can SLT give us a good understanding of where the resistance to outflow is. Because preoperatively, when we're doing our gonial prisms and looking at our angles, what are we looking at, right? Is it open? Is it closed? You have PAS? What's the pigmentation, et cetera? Is there NVA, et cetera? But really, we can't tell where the resistance is. Is it TM, Schlemm's canal, or even distal that's causing the problems? And I think SLT, because it works primarily at the level of the trabecular meshwork, the pigmented trabecular meshwork, and that's where the source of pathology, if it works, there's a chance that, hey, that means your distal channels are probably doing well if you have a good response. If you don't have a good response, assuming you did a good job doing laser, then it could tell you that the resistance is probably in the canal as well, or the distal channels. And we'll talk about data that supports that potentially. But really, I think the light trial, just going back to kind of some recent data that's, I think, reinvigorated a lot of our excitement about SLT first line, is a light trial by Gus Garzarter and his group, basically showing us that patients who were compared between SLT and latanoprost generic over 4 years as a new start found that both had good response, about 30+% reduction of IOP, which is what you expect from a PGA and SLT. But the key is majority of patients, actually, if you no patient in the SLT group transfer or progress to needing incisional glaucoma surgery, like a trab or a tube, versus the people in the medication group, actually 11 of them needed to be having to have an incisional surgery. And there's also significant cost savings to the UK health system because of the adverse events, because drops, and even quality of life issues. So I think there's no doubt that SLT has shown us it works well, but now we have a great randomized controlled trial that shows us the benefits. And there's been other data out there from many years ago. Jindra showed a great data with first line therapy and showing that it has more longevity. The earlier that you actually perform SLT, the better chance you have of it being endure some effect, because the thought is healthier TM, healthier outflow system, the better chance you can maintain that long term as well. And so you had a very good 5-year follow-up. And there's just, again, a few other studies showing us, McIlrath and Katz shows data comparing SLT to latanoprost many years, not a randomized controlled trial, but it does show the same thing. And even Francis showed us here that you get a good job of reducing the drop burden. So as replacement therapy, so even if it is, let's say, not a first line, people are already on latanoprost and a bunch of other, let's say, generic medications, or compliance is an issue, doing SLT can get you off of sometimes 1 or 2 even more meds depending on the situation. So I think as not only as a first line, but as a replacement therapy can help. And comparing even to latanoprost, which is I think important as well, even though we do know from Weinreb studies in California doing the sleep lab that PGAs do blunt the nocturnal IOP rise that we see, SLT also further blunts that. And I think that's an exciting topic that we don't talk a lot about, but can it more flatten that nocturnal rise that we see in those patients who may be susceptible to fluctuating IOPs or even blood flow issues? And so if you have a normal tension patient, sometimes, you may not get, let's say, a significant reduction of pressure from the SLT. Let's say your pressure is 15, 16 in range to start with. SLT gets you down to 13, 14 because of EVP. It's hard to get too low. yet it may flatten that curve and maybe help that nocturnal IOP as well. So that's kind of something that I look at too when I'm thinking about SLT. Can I flatten that nocturnal curve, especially those patients who are more at risk as well? And so what's nice about it for the surgeons and for those of you optometrists out there who are in those states you're doing SLT, I just like it so much because it's really hard to not know where you're looking. I mean, the aiming beam here is about 400 microns. The laser is 400 microns. The TM is about 120, 130 max width. So you're just as long as you paint that red beam over the TM and just fire and look at those champagne bubbles. I start about 0.5, 0.6 millijoules. I'll go up if they're heavily pigmented, go down or stay at 0.4, 0.5. If they're light pigmented as well, I don't see any champagne bubbles. I'll go to about 0.8, 0.9. But 1 is really where I kind of have to max out. I don't really ever go back above 1 millijoule. But again, it's a very straightforward, I think, efficient procedure, easy to do compared to even ALT was. So that's why I think it's a great first line option for patients. But I think for me, it's really because of MIGS and because we're now talking more about mechanism of action, I think SLT provides us the ability to give us a little bit of a diagnostic potential, like I was mentioning earlier. Looking at our iStent data, as I mentioned earlier, we find that when patients have, a fast forward here, when patients have SLT and they've had a good response to SLT, we found in our iStent data, so our first 100 iStents, this is the first generation a few years back, and Glaukos came to my office and kind of mined my data. We looked at our first 100 patients. We said, okay, let's look at the outcomes, and the iStent did great. But what we found is in the subset of patients who had previous SLT, and the people who had a previous SLT that had a good response, greater than 15%, we had a better response to iStent and lower pressure, but also less number of medications needed over a year plus. Number 2, in the patients who had a poor response to SLT tended to have higher IOPs and on more number of medications as well. So it was, again, this is not a published data, this is my own data to be fair and balanced, but I do think this is something that we're looking at with some other doctors, Arsham Shabani and Mark Gallardo and others, and Nate Radcliffe. We're all looking at this data to find, are there some correlations? Can we use SLT to help it as a surrogate to where the resistance to outflow is? Again, if SLT works great, that's telling you you probably have a good distal channel or good distal pathway. If it doesn't work, it might be because you might have some resistance beyond the TM as well. And I think the patient selection is so broad. We have people from OHT all the way to more secondary glaucomas with mild, moderate, or even advanced disease. There's no restrictions on that as well. So I think as long as they have an open angle, I can see even post LPIs, deep in the angle, you have this combined mechanism glaucoma, you do an LPI and they open angle, but yet there are still high pressures. You can actually revitalize. I've actually had some significant amount of success with post LPI patients as well, where I can see the drain. Of course, people who have pseudo-X and pigmentary do a very good job. Steroid-induced glaucoma, a great opportunity for SLT because we think the TM is the main source in those patient populations as well. So I think it's a number of variety of patients as well. So in a nutshell, I think SLT first line makes a lot of sense. It's easy for the patients, easy for the providers, easy for those of you who don't do SLT or co-managing or seeing all these medical patients after it's being done. It just makes your life easier. We actually found that when you decrease one drop in the eye, our efficiency and flow of the office goes up. So with every one drop that we get rid of for our glaucoma patients, our techs have saved 4 minutes of time per patient per visit. How do we do that? We had our head technician keep a track before we did any MIGS or any SLT, before we took them off meds, of how long it took to see patients, callbacks, confirming the drop regimen that they're on, et cetera. We found that with every one drop you decrease, 4 minutes of improvement of time. If with the second drop, it total about 5 minutes total. So it can help the efficiency and flow of the office, which I think is really important as well. So it's a little bit of SLT, kind of my kind of go-to first line for a lot of my patients. I think describing it in a way that rejuvenates, it's a beam of light, has really helped the adoption versus saying I have a laser. All of a sudden patients go, laser, no. And they say, I'm not doing that drop, put a drop. And again, when we talk about standard of care, patients will look to us as providers of what is standard of care. And so I tell my patients in my practice, this is my standard of care in my practice. There's enough data supporting this is a better option. If it was me, I would do this first line. In fact, at the AGS a few years back, they asked the whole audience, how many of you here would do drops first or SLT first? And I think it was like 88% or something like that said, yes, I'm doing SLT first. How many of you actually do SLT first line? It was like 34%. So again, there's a disconnect to what we would want for our own eyes versus what we want for our patients as well. So a little bit about SLT. I think SLT, along with drug delivery, has a great, safe, I think, efficient way to allow us to intervene earlier and get these patients at least to be off on less drops for a period of time early on. And so I think drug delivery is exciting and it's really something I've adopted in the last year and a half since Durysta became approved. And right now we have biodegradable implants, Durysta we'll talk about, and Ocular Therapeutics is working on their phase 3 trials right now. We also have the iDose we'll talk a little bit about, which is Glaukos's canister of travoprost, and I'll show you a video on that as well. And we also have rings and other external implants in the punctum and canalicular system that releases it over time. So real quick about Durysta, talk a little bit about this, because this is something that I've utilized now in my practice for the last year and a half since approval. And I was part of the phase 2 and phase 3 investigations as well as studies. And it's pretty cool. It's basically a biodegradable implant that you guys, I'm sure, have heard of now already, and are probably using and co-managing as well. But it's 1 drop of Lumigan, 10 micrograms of bimatoprost impregnated into this basically biodegradable implant that releases medicine for 4 months. But the effect can last up to 2 years in about 25% of patients. So there's an endurance effect. We'll talk about that and why that might be as well. But it comes in a platform called it's like an Ozurdex. So those of you who do Ozurdex or have people in your practice doing that, 28 gauge needle with a nice loader that basically shoots it into the anterior chamber and it releases medicine over 4 months. That's what the loader looks like. There's a little actuator button where you actually press it to release it. And this 28 gauge needle is strong enough to go through the cornea without bending, but not too big where you have low risk of leaks. And so what I do in my technique is really doing it at the slit lamp. I don't do it at the lying down anymore. I think it's more convenient for the patient. I don't use a speculum anymore. I think the speculum itself can irritate patients as well. I have them fixated on a point on the slit lamp. I have a technician holding the head forward, and I anesthetize the eye. Also, of course, aseptic conditions. I betadine scrub, make sure there's no MGD active, etc. And then I just go in there. And this is real time. Just basically go in there, engage the. Hopefully, you can see this here, but I'm going to engage the and the anterior cornea here, but right just anterior to limbal vessels, parallel to the iris, go over the iris, press a button in a second here. Once I'm about 2 bevel lengths in the anterior chamber, press a button and come right out. And that's real time. Patients say, doc, that was like a pressure check. So it was very straightforward for them. Slow motion, I press it halfway. You can see this little pellet come out and the implant, and then press it again to fully push it forward. And it just goes in the anterior chamber. What's great about it is it goes in the anterior chamber and eventually will sink down to the inferior angle. So people have to be open angle for this. Of course, grade 3 or greater Schaefer grade is what we recommend, because it does sit in the inferior angle for months and months, even a year plus. It can stay there. The vehicle doesn't dissolve right away. And so we want to make sure that there's nice open angle so you don't get corneal decompensation. It sinks to the bottom and you really can't see it after it's fully sunk to the bottom. Sometimes a little air bubble gets attached to it, like you see right there. And that'll take a little time, but eventually it goes down to the bottom and sits there. And it's this tacky material that allows it to sit in the inferior angle. So we don't really see it floating around. Here's another video just showing you again the same idea. Anterior to limbal vessels, parallel to the iris, go into the eye, 2 bevel lengths, press a button, come right out. Sorry about the focus. But the idea is it just goes into the anterior chamber and that's it. I don't put them in any post-op topical antibiotics. There's no restrictions. I tell them just don't go like hang on their head or don't do any downward dog for the first day, let it settle down for 1 day, but then at normal basic activities, and I stop the topical PGA as well. So I think there's definitely some great evidence about the benefits of this. If you look at the data on actual concentration of bimatoprost in the eye versus external, if you look at it compared to topical medication, bimatoprost 10 micrograms, much more concentration in the ciliary body of aqueous humor during taps than with topical bimatoprost. But looking at the external tissues, right, the lid, the conjunctiva, orbits, etc., comparing to the outside of the eye, we don't see much of it at all. Just a small amount seen in the conjunctiva, and that's it. Majority of it was actually only in the eye. So people who have issues of hyperemia, lid lash growth, periocular pigmentation, MGD issues, these are all issues that we face every day. And having a bimatoprost intracamerally decreases the chance of those issues happening. What really, though, is exciting, I kind of find myself geeking out a lot about, is this idea of, can we change the actual morphology? Are we actually changing the pathogenesis or the progression of glaucoma, or pressure rather? And why? Well, if you look at the topical bimatoprost and looking at histology slides, you're seeing remodeling in this this B column here, or this picture. You see these larger spaces in the ciliary body, versus in vehicle control, they're more tightly packed together as well. And so having bimatoprost has been shown to actually open those spaces. And having it 24 hours a day intracamerally, what we find also is an increase in the expression of MMP, metalloproteinase. Because if you think about it, normal healthy eyes, right? What we have is an increase in pressure. Our body is releasing, overexpressing metalloproteinase and decreasing the expression of TIMS, the tissue inhibitor of metalloproteinase. Now remember, metalloproteinase is what releases macrophages and cytokines to open up the TM, the extracellular matrix. So we don't have that response in glaucoma patients. And what you're seeing compared to topical is that, and if you see here in the red is the bimatoprost with sustained release intracamerally versus black is topical. You see this in the red column, more increased expression of MMP and decreased expression of TIMS, a tissue inhibitor as well. This to me is one of the reasons why we're seeing longevity of effect, why we're seeing in some patients get responses well beyond the 4 months of release. In fact, if you look at the data in the phase 1/2 trial, where it was just 1 implant, 26% of patients had 2 years of efficacy without needing any rescue therapy. And 36% had 1 year of efficacy, even though it's only releasing for 4 months. That to me is probably because of the fact that we're probably having some type of remodeling. In the phase 3 trials, which is 3 implants every 4 months after the third implant rather, 86% of patients had 1 year of efficacy without any rescue therapy. So there might be a loading dose. The problem is right now, Durysta is only approved for 1 insertion because they want to make sure, the FDA wants to make sure there's no issues with endothelial cell loss. And we'll talk about that in a second as well. But it's a very safe medication. We're seeing issues of like hyperemia, et cetera, being extremely low. Now you'll see here 27% in the studies. But the top 5 issues here, eye pain, photophobia, conjunctival hemorrhage, these are all from the implantation itself. After that, we did not see significant issues there at all. There were some people, there's a couple people who had some small iritis, some inflammation. Only 1 had to be removed because of inflammation. And that patient had a history of uveitis, so it had a more of a complicated history as well. And endothelial cell loss is very rare. We'll talk about that in a second here. With 1 insertion, 1 implant, 0.9% of patients had any type of cell loss, but less than 10, between 10 and 20%. So insignificant. Even in the 3 injections in the phase 3 trials, 5.4% of patients had, again, 10 and 20% of cell loss. So again, not a very common or very large amount, but the FDA wanted to make sure, just to be safe, before it started telling people go ahead and just keep doing it, how often do we do a treat and extend like our anti-VEGFs? And so I think that's where you're seeing now Allergan, about 4 or 5 studies right now looking at this idea of treat and extend and how often do we have to insert it. But that's, I think, the limit for some people. Now, the way I address that in a case like this here is, in general, is that, look, I don't tell patients this is a cure-all. Everything we do in glaucoma, we're just trying to minimize the effect or minimize the progression at that point in time the safest way possible. But I tell patients all the time, guess what? We're going to have to do something else. So because the insertion is so benign for the patients in the office, their expectation is different than, let's say, going to do a glaucoma surgery like a TRAB or even a MIGS procedure at the ASC. So patients are happy having like a let's say like a contact lens holiday. They have a drug holiday here. Give them some time off of the meds, save them some cost. Medicare Part B covers it. And so a lot of these patients where cost is an issue, if they have a supplement, it's cash flow neutral for them. It's actually cheaper than having drops, even for 4 or 6 months if it gives them a break. So here's an example of a patient where that was the same idea. Essentially, it was an African-American male, not a white male, but an African-American male with high blood pressure, et cetera, had cataract surgery in one eye, SLT, and it was on latanoprost, having a hard time taking meds, fluctuating between 18 and 23 or so millimeters of mercury, had low hysteresis. I'm a big fan of corneal hysteresis, which is, again, hysteresis is a shock absorbing ability of the eye. What's the eye's ability to absorb and disperse energy? Felipe Medeiros at Duke has done some great work showing us that actually hysteresis has a higher predictive value to progression for glaucoma than even pachymetry. And so for me, I think hysteresis is a great opportunity to see. If I have a patient, let's say, who's ocular hypertension and their pressure is 26, healthy nerves otherwise in normal fields, I'm going to watch them if they have a healthy hysteresis. 10.5 is normal. So if there's like 11 or 12, I'm much more relaxed to say, come back in a year. If their hysteresis is like 8 or 9, like you see here, I'll treat them at a pressure of 24, 25, because I do believe that there's a higher risk with those patients as well. So he had a history of Tmax in the upper 20s on latanoprost, ranging between 19 and 24. And he actually tells you, hey, doc, I'm missing my drops. So whenever someone tells me that, that's a bad sign, because majority of patients, as you know, don't tell us that. So he's like, all right, I need something more, doc. And he had look at his SPK and his EBMD, if you look on the right there. So his surface of the eye was causing significant issues. And I tell you, for those docs out there who say, hey, man, I don't have time to document dry eye. I don't have time to actually do diagnostic testing. I don't have a dry eye center of excellence. My perspective is, don't even worry about the diagnostics. Just ask the patient. The patient says, my vision comes and goes, so I have to blink my eye to read, or I'm driving, I have to blink my eye, or I have to watch a TV, I have to blink to clear it up. That is ocular surface tear film instability. And there's majority of the time patients are having some issues with either lipid layer or their aqueous layer in those patients as well. So dry eye issues, having a hard time with drops. He had a low hysteresis, early cataract in one eye, but pseudophakia in the other eye. You can see the color difference here because of pseudophakia in one eye, but not that bad. The nerves don't look too bad at all. Maybe some inferior thinning here a little bit, but not a bad nerve at all. And his nerve fiber layer looks pretty good too. But this is where I love the GCC guys. As you guys all know, I think the ganglion cell complex does a great job of helping us determine some of these earlier glaucoma patients where the fields look pretty good or the nerves look okay. And yes, you can see larger cupping in the right eye, maybe some inferior thinning here of the nerve fiber layer, but it's all green here, right? We say, hey, green disease. Having a little bit larger cup volume, which could be a sign of glaucoma. You could have some nasalization of these nerve fiber layer here, which can sometimes happen. But basically, when the GCC shows inferior loss like that with that nice kind of horizontal raphe, I do think that this is a very common sign of glaucoma. And when I did my training at Duke with Sanjay Asrani, he was one of the first people in the world to talk about the GCC. He has something called the retina thickness analyzer, RTA, which basically was the same thing as this, showing us early on in glaucoma, you can see thickness changes in the macula before you see an fiber layer. And I always tell my colleagues and a lot of residents coming out of training that there's so much more variability of the optic nerve, right? Myopic nerves, larger nerves, smaller nerves, where the vessels come out, versus the macula is pretty consistent between people, unless you have some other macular pathology like AMD or some other geographic atrophy or something from myopia. Really, majority of patients have the same type of macular thickness in general. So I think there's more consistency in the macular region. So he had some OCT progression inferiorly, as you can see here. So again, fields are pretty good. And basically, this is a guy who has really early glaucoma, but not compliant. Perfect candidate to say, hey, man, let's just go ahead and put you on a drop, give this Durista in there, get you off the drops for a period of time. His pressure has been in the middle teens. He's been about a year out. He's still doing well off the medication. So I do think this is an opportunity for a lot of our patients who, let's say, are suffering with drops, not compliant, give them a period of time. And look, if they have to go back on drops, you gave them some time off. And incidentally, what I've noticed too recently is patients who have had Durista, and I found that what they found is that patients who said no to a MIGS procedure, who had this implant and are been off of drops, when they have to go back on drops, they're like, hey doc, I think I want to have that MIGS procedure now. Like, again, to give you an example, I want to do canaloplasty. As one patient, he said, no, I want to hold off. I'll just take drops for now. I said, let's try this Durista and see what happens. Got him off the medication. He came back about a year plus, starting to climb up again. And I said, okay, let's go ahead and put you back on that drop at night. And he's like, you know what, doc, I really love being off of medications. Do you mind if we now think about that surgery talked about before? So it's like a bridge to get them comfortable considering a surgical option. So again, long story short, the perfect patient could be anybody with compliance issues. If they're open angle, I think anybody could benefit from this potentially for a period of time as well. Now, post-MIGS, pre-MIGS, getting people to get ready for a Zen, for a trabeculectomy, because we know the more inflamed their conjunctiva is, the more risk you have of fibrosis and scarring. So if I can do this, get them off a PGA, put them on, let's say, Diamox for a few weeks, get their pressures to stay down, I can have a better chance of that surface being healthier, less chance of scarring for my trabeculectomy or my Zen procedures as well. So I think it's a great option too, even in those kind of patients, to get them off of some meds to prepare the eye for surgery as well. So again, that was just a study I was showing you about with the tech savings time. Again, 4 minutes of savings for every one drop that we were able to decrease with these technologies as well. Just real quick about what's coming on the market soon in the next couple of years. Travoprost implants, Aga Therapeutics has their version of Durista, basically, which is the same principle as you saw with the Durista, same idea, intracameral, injected into the anterior chamber and let it kind of sit in the anterior angle. And they're basically showing the same type of data as well. You can see here what it looks like. The difference is they like to impregnate with fluorescein, so you can see it well in the anterior chamber. A little bit longer than the Durista, but very similar type of technology. They're getting a very good response of like 10 millimeters of mercury at 6 months, sustained over a year, almost a year, but 9 months here as well. So they're under, that was a phase 1-2 trial. So they're in phase 3 right now, which we're a part of as well. So we'll see how that goes. There's other companies too working on things. Envisia Therapeutics is working on their as well, intracameral implant, about 7 millimeters of mercury, not quite as robust as the Durista and the Aga Therapeutics one. But there's another technology you can see in this picture here, what it looks like in the inferior angle again. So they're still working on their phase 2 trials, from my knowledge. What is going to come out hopefully soon, and what has finished their phase 3 trial recruitment now, is the iDose. And this is something you probably will see in the next couple of years as well. And this is basically a intracameral canister of travoprost. It's actually a proprietary travoprost oil that Glaukos has kind of helped to develop. Well, they basically just implant it kind of like an eye stent there. This is one of my first cases there. You can see I'm a little heavy with my going to prism, so that's a little corneal edema there. But you can see I'm just going to insert it into the nasal angle. It has a little trocar that allows you to go into the scleral wall, and basically just tap it side to side to make sure it's embedded into the scleral wall, and just sits there kind of parallel to the iris, and it releases travoprost oil over a period of a couple of years actually. And they're having good longevity of effect. In fact, their data shows you're getting about 2 years of efficacy, about 7 to 8 millimeters mercury reduction as well. So the difference between that and, let's say, Durista is that this is going to last a bit longer, most likely. And where I see this fitting is going to be at the time of your MIGS cataract surgery. That's, you're already doing MIGS or even a standalone MIGS procedure, and you're like, hey, I'm already there doing my canaloplasty, my Omni, whatever, KDB, my iStent, Hydrus, whatever you're doing. You go ahead and just put this little baby in there, and it lets it also release a PTA for the next couple of years to kind of also help, again, keep that pressure down. So maybe a good adjunct to your surgical options, especially for already there doing surgery as well, because the insertion is very similar to that of an iStent. Last couple drug delivery things that are going to be also being looked at right now. One is by Evolute here by Madi Therapeutics, which is basically they have a kind of a nice a canister type of system, it's called a stable fit, which is basically a platform for then you to kind of insert these little plugs that you can replenish over time. So they have good stabilization and good retention rates. Back in a day, when people try to put punctal blood drug delivery, there was a number of patients where the plug would kind of fall off. And with this stable fit design, they're able to have a good higher retention rates. In fact, about 98 to 96% retention rates as well, which is I think is a very important concept if you're going to try to use this platform to release medicine as well. And then there's the last couple here. Morphex is a company that's looking at, again, a dissolvable gel material that goes underneath the lid and the superior fornix that also stays there, kind of suction cups to the eye and allows it to release medicine over a few months to up to 6 to 8 weeks as well. Probably not going to be as universally used because of the longevity is a little shorter. And then the bimatoprost ring has gone through some manufacturing issues. I know they were supposed to be in their phase 3 trials as of the spring. Not sure if what their recruitment looks like, if they've started or not, but with some manufacturing issues. But again, bimatoprost ring that goes externally versus having an intracameral or any kind of punctal plug delivery system. So the bottom line is drug delivery, I think, is here to stay. I think you're going to see more and more different compounds being utilized. Again, longevity of effect is going to be important. But I think you're going to see that now with Durysta and even coming in the future as well. So again, that and SLT, I think, is a good combination to really get us to the point where we can get a lot of these patients safely in the office off of 1 or 2, even sometimes more meds. Because what I've noticed with drug delivery is that, people on let's say 2 or 3 meds, generic, let's say manufacturers, the eyes are dry, they're not using them. You do a Durysta in those patients, they come back and not only they offer PGA, sometimes they're offered timolol in the morning or they're carbonic or something like that because, again, compliance is so bad. They're just so much better and I have to worry about taking it. And less inflamed eyes, I find time to find pressures come down because we can get a little bit of trabeculitis when you have an inflamed eye as well. So again, long story short, great to use those technologies if you can in the office. So that's kind of, I think, the drug delivery SLT group. But now we're going to talk the rest of the time on MIGS and kind of what MIGS has done for my practice and for a number of surgeons and number of providers out there. I think it's sparked a number of different, developmental areas. Number one, I think it's now being able to tailor our treatment regimen and our products to the patient itself versus just one shot fits all. Do a trap, because we couldn't care less about mechanism of resistance before, right? Before we had MIGS, it was like, okay, drops until finally you need to do a surgery and it was just do a trap. So who cares what the resistance is? Just put a hole in the eye. As long as your conscious healthy, you're fine. But now we're actually dealing with mechanism. We're understanding TM versus Schlemm's canal because these MIGS procedures work in different levels of the pathway. And now I think non-glaucoma specialists, comprehensive eye docs are being able to now utilize different technologies and treat glaucoma surgically, not have to send them out as well. And I think we're going to see now a new emphasis on quality of life and even new diagnostics that can tell us where the resistance to outflow is preoperatively, so you can better understand which of these devices is the best for any individual patient as well. So exciting times ahead. But what I am concerned about is the fact that the adoption, if you look at the market scope data, hasn't really grown. This is actually from glaucoma surgeons looking at the responders who from a questionnaire, showing us that really it's pretty flat. In fact, a number of percentage of doctors from Q2 of 2018 to Q4 2020 is very similar, which is the number of doctors who are not offering in angle-based MIGS, like a stent or hydrus or one of those kind of procedures as well. And these are glaucoma specialists. So it really hasn't changed enough to my perspective. And even amongst cataract refractive kind of comprehensive surgeons, same thing. We see a little bit more growth there, but still kind of flat. And I'll tell you why I think that is, because still there's a perception that MIGS doesn't work as well, either it takes too long or it doesn't work as well. It's not really worth it for patients. But now I'm going to show you some data. I think we have enough data that does support there's a benefit than just doing cataract surgery alone. But it's interesting to see how it hasn't grown like we thought it was going to grow. And I think to me, it's because, again, it's this philosophy of waiting to treat patients. And the philosophy, I'm going to fast forward to this for sake of time here, but the philosophy is this, and this is the main point I'd like to make. And this is more of just a kind of a philosophical discussion here. But what I've changed in my philosophy at home is instead of seeing a patient who has cataract and glaucoma saying, oh, I have a cataract patient who happens to have glaucoma. When I have a glaucoma patient develop his cataract, I look at it. I have a glaucoma patient now who has a cataract, an excuse to go into surgery. So I know it sounds simple, right? But it's a mindset of, look, I have a glaucoma patient first who now has a cataract. So I'm going to take care of that glaucoma. That's the main pathology for that patient. The cataract is just an excuse to go to surgery versus, oh, I have a cataract. I'm going to take care of that cataract isolated from the glaucoma patient, right? So to me, it's a different train of thought. So anybody who has glaucoma, I think, deserves a chance to have some type of MIGS procedure to minimize their drop burden, to get their pressure down if they can during cataract surgery. And that's something I still think was taking time for a lot of our colleagues around the country to kind of have that mentality. And I'll share with you some data that really I think now gives us more, I think, understanding of the benefits of it. But to the point I want to make earlier is that we have no perfect solution. There's a lot of different products out there. I do all these different products. This is one of the days I was in surgery. And I was like, holy cow, I have like all these different products I'm using in one day. That just showed me and demonstrated the fact that there's no one right or wrong answer. We don't have a perfect surgery. And it just depends on your anatomy, the pathophysiology, their target pressures, and again, your comfort level as a surgeon of what's the best option. But I think it's important before we go into the mixed discussion and talk about I think which procedure and for what patient, et cetera. It's so important to understand, again, remind ourselves that the canal is not equally distributed and equally patent throughout. We have areas of collapse of the canal, and that can be important when we talk about different MIGS procedures and the efficacy and longevity. Because Hyeon Gong has shown us, who's from Boston, she said some great work showing us that there's actually a complete collapse of canal and blockage into the ostia, herniations that block the ostia, the collector system, in about 50% of our POAG patients. Here up top here is a nice, beautiful patent. This is a histology slide showing us a nice open Schlemm's canal, and then it's the opening here, that CC up top, is the opening into the collector system. On the bottom is a typical POAG patient where you have a blockage here of the canal, you have a little bit of some patent canal here, but a blockage here, and guess what? You have this complete blockage over that collector system. So if you're putting a stent here alone, let's say hypothetically, you may not have a chance to get a good amount of flow because you have collapse of that collector system next to it as well. So that's one of the reasons why we sometimes have to combine different mechanisms. And we'll talk about that in a second. And here's just her data in 2015 at ARVO showing us about 50% of our patients have a complete blockage of the ostia into the collector system. So I think that's an important concept. We talk about different mechanisms of our MIGS procedure as well. So when I think of glaucoma now, I think of glaucoma, I stage it based upon field loss, mild, moderate, advanced glaucoma, right? The more advanced the glaucoma, the lower that target pressure has to be oftentimes. And that gives us, again, target pressure. But I also look at resistance staging. To the point I made earlier, what is the likelihood of resistance beyond the TM? Here's how I do that. They had failed SLT. If they're on 4 or 5 medications for 15, 20 years, guess what? There's a likelihood they have resistance beyond the TM. If I have a patient's pressure is 24, mild glaucoma, pre-parametric glaucoma, but the pressure is 24 on 4 meds, pressure, let's say 20 in the middle 20s, that's someone who probably has resistance beyond the TM. I'm going to hedge my bets and also do something in the canal or distal channels as well. So I think a combination of the target pressure of what is a staging of disease, and then your thought of where the resistance might be. We don't have great diagnostic tools yet. There's a number of companies working on tools, not with a minimally or non-invasive way, preoperatively to understand where the resistance to outflow is preoperatively. Can we understand before surgery where the resistance is to tailor our treatments? We don't have that yet. So the surrogate is failed SLT, like I said before, number of medications, and where the pressures are at. That tells me kind of where the resistance might be. Because again, we have a lot of options, right? We have conventional pathway MIGS we'll talk a lot about. We have some newer technologies in the supraciliary space that are being worked on right now. A company called iStar Medical is working on one. There's a company called Glaucos that has, as you know, that has a supraciliary stent that's they're kind of watching right now and looking at the data. We have also external bypass. We still have Zens and pressure flow coming out, which is Glaucos going to co-market with Santen, which is another subconscious stent. And we also have, we can't forget ECP and cilioablative procedures like micropulse to decrease how much fluid the eye makes. So we have a lot of options in the surgical realm, and it's hard to do all of them. But I think there's a rationale to use each one of these different products in different situations. So we have our stents, and I tell all new surgeons, pick one of these products from each of these categories. Pick an iStent or Hydrus. Try to get comfortable with those devices. Try to a conventional outflow canaloplasty procedure like the iTrack catheter or the Omni device. These are both devices that dilate the Schlemm's canal and release viscoelastic to, again, break those herniations in the canal, right? Those blockages we showed you with Hyeon Gong's work, and then flush out the distal channels. The iTrack catheter by Nova Eye and Omni by Sight Sciences both viscodilate. There's some nuances I'll talk to you about in a second. And then the right is the stripping or cutting procedures. We have trabectome or KDV hook dual blade that can remove the trabecular meshwork. And we also have, of course, the Omni that can do some cutting as well, as you can combine viscodilation and cutting with the Omni device as well. And so the key to the question that people ask me all the time is, well, Paul, how much of the angle do we have to address, right? How much of the collector channels or how much of the canal do we have to dilate to get a good effect? Well, if you look at data from Alex Wong, he's done some great work. He's shown us, even in healthy eyes, majority, if you look at, let's say, fluorescein dye testing here in healthy eyes, cadaver eyes, where the outflow channels are really nasally, right? The most of our collector channels and the density of the collector system is in the nasal, inferior nasal quadrants. So if you can do a 90-degree otomy or 90-degree canal dilation or something, even there, we found in data a good effect. So we don't have to necessarily go 360 to get a good effect. The question is, how many distal channels do we have to access to get a good amount of reduction? We're seeing now with data coming out, around 2 or 3 good collector channels that we can access can give us a good amount of response to get down to that middle teens, which is where a lot of our patients are good at based upon their disease. So real quick on a couple things on the iStent and Hydrus, and just a kind of an overview of some of the new things that are happening and some new studies that have come out. As you all know, the iStent had the Inject, which was their newer version after the original G1, but now they have the iStent Inject W, which is the wider flange. This wider flange here, which just came out a couple of years ago, is nice because it does prevent over implantation. Sometimes with the iStent, it was hard as a surgeon to know how much pressure to put at the nasal angle. If you put too much pressure, it would over implant and get sucked into the TM. Or if you didn't implant it hard enough, didn't put enough pressure, it would sometimes not stick in the canal, and you have to kind of maneuver it and try to rethread it. And so that's the iStent Inject W, which we'll talk about. And on the right is the Hydrus, which I like a lot as well. This is a stent that's 8 millimeters in length. It covers about 90 degrees. And what it does do, unlike the iStent, it actually also goes into the canal and scaffolds the canal. Remember those herniations we talked about? Well, it allows us to break those herniations, scaffold the canal long term, and it has a little inlet on the right here that bypasses TM. So it does bypass like the iStents, but it covers a larger, wider area and also allows us to scaffold part of that canal. And so a little bit about the Inject first, and we'll talk about the Hydrus. But the Inject is a great device that I think is very user-friendly. The new W not only has a wider flange, it has a little bit smoother implantation, a smoother process of inserting it into the canal, so less amount of pressure needed to get a good implantation in the canal. You can see on the left is the regular iStent Inject, the original, and the right is a W. You can see the difference in the size of the actual stent facing the anterior chamber, so harder to over implant. But a key thing that I tell all my colleagues, anybody who's doing MIGS, is the view. I don't care how smart you are, how good of a surgeon you are. If you don't have a good view, you're not going to have a good procedure. Here's a view where a lot of docs will say, hey, you know what? This is not bad. I see the trabecular meshwork, that brown line is where those arrows are, but I don't see the scleral spur. And the TM is almost facing downward. As a surgeon, you want the TM to face you. We want to have an en face view. So as I press play here, I want to show you what I do with this kind of surgeon or this kind of a patient. I'll stop and say, okay, you know what? Let's go ahead and turn the head and the scope a little bit more, right? Just to take the time. Don't be a hero. Take the time, turn it more. And now look, now you have a beautiful gonioscopic view. Now you see the TM facing you, and you see that little white line, which is the scleral spur. I can't tell you how many times I see videos from surgeons who are having a hard time with X, Y, and Z MIGS device with the conventional pathway. And what's happening is that their TM is probably facing down, or they're facing too far like that, too much rotation. And so having this en face view facing you is probably 90% of the battle of any of these MIGS procedures. When you have a good view, it's a lot easier to go ahead. And you can see on the left is a poor view, where it looks like you have TM. On the right is where you have that nice en face view. And that's where I think a lot of surgeons make their mistake. So anybody thinking about doing MIGS in the future, and those states that allow you, eventually, that's a key, getting a good view of the angle. Now you want to be as perpendicular as possible here. You can see I'm going to turn my hand a little bit to the right just to make sure I'm more perpendicular, because if you're not perpendicular, sometimes that stent, that trocar will bend and it won't actually sit in the canal very well. So now I press a button, I relax my hand, a little too much pressure, so I relax it in a second, and then I press the button. And go ahead, nicely in the canal there, and go 2 clock hours away. Now I'm losing my view because I was pushing so hard, some viscoelastic came out of the eye. So I'm going to say, let me not be here. Let me go back in, re-inject with some more viscoelastic here, get a good view. Again, the view is the most important. Now I have a good view in a second here, put more viscoelastic on the cornea, and I have a good view. I can go ahead and put my second stent, press the button, press the stent, and then boom, we're done. And so there you go, those 2 stents in the nasal angle, 2 clock hours apart. The reason why you want to be 2 clock hours apart is because you want to have access to more distal collector channels. And studies have shown in Armenia that if you're not 2 clock hours with your second stent, what happens? You lose about 50% of efficacy of that second stent. And that's why it's important to try to get 2 clock hours away. And you can see here, nice blanching of the nasal angle. What I love so much about doing these surgeries intraoperatively is eye candy. When you see a whitening, where all of a sudden you're like, wow, we blanched that. We really did improve outflow facility in these patients as well. So even those 2 small stents can give a significant amount of outflow improvement. Well, 1 second, guys. Sorry, guys, 1 second here. Sorry, they were calling me for this meeting, but it's okay. So just to show you here, I'm going to go ahead and show you what the W looks like here. This is the inject W now with the wider flange. And what I'm going to do, I'm going to show you in the second stent, I'm going to try to over implant it. I'm going to push really hard. You're going to see a lot of corneal striae. I'm pushing hard, hard, hard. See the striae? I was pushing hard to see if I could over implant. And even when I pushed really hard, it was very hard to actually over implant it. So that was one of the reasons why we see a benefit of this W is larger, wider flange. So that's one of the nice things about it that I've seen a benefit as well. So real quick, just for sake of time, I'm going to fast forward, but is a case with a cataract. It's clinically significant cortical nucleus sclerotic changes. Patient have a hard time with glare, had SLT historically with good response, so probably have good collector channels as well. I'm a big fan of multifocality, of not doing multifocality, but doing toric lenses in patients who have glaucoma. Here's a patient with the IOL master, with the Penacam tomographer, as well as the eye trace on the right here, which is a cool device that does really ray tracing. It can separate cornea versus internal optics, and it can show patients beautifully what the ramifications of taking care of astigmatism is. So here's a patient here that has astigmatism, right? So I say, look, on the right here, on the bottom on the right here, you see a little eyeglass with a little red line. This is the eye trace telling us this is what it would be like if I took care of your regular nearsighted, farsighted with the standard lens, but not take care of astigmatism. Now here, if I press a button, boom, that's what it looks like if I take care of astigmatism. And that's the quality of vision improvement. So it's a way to show and educate patients. On the bottom, you can actually show them their topography, their wavefront Ks, and show them the axis of astigmatism as well. So this patient had significant astigmatism as well as glaucoma on meds. You can see here there's some progression inferiorly of their nerve fiber layer. So this patient, no doubt, is having significant loss of nerve fiber layer over time. And you can see here, and the fundus photograph, some inferior thinning of the rim here in the right and left eye, almost a notch forming there. So definitely real glaucoma. And if you look here at the fields, even though the left field doesn't look horrible yet, you can see a significant pattern standard deviation loss there. And the right eye, you can see a focal defect here as well showing up. So no doubt moderate glaucoma in these patients, where this is a great opportunity to get early adoption, get the cataract out, get them off their meds as much as possible. So I went ahead and did an eye stent with a toric lens as well. And patient did great. I was able to get their pressures down into the middle teens off of medication, and quick recovery, as you all know, with the eye stent and the toric lenses. So kind of a real life case that I like to use a lot as well. Any questions? Make sure I missed any questions here. Okay, cool. So we're here on time. Okay, good. So just real quick about this question of, does phaco do all the work? Because one of the limitations, I think one of the pushbacks of why surgeons, as I mentioned earlier, are not adopting MIGS is because of the fact that we see a number of our doctors say, I think phaco is doing all the work. Well, eye stent's not doing much. Well, this is a study that just got published. I was one of the investigators for the study. It was a phase 3 trial we looked at. We looked at the phase 3 trial. We basically did a post hoc analysis, and we segregated the patients based upon their pre-op unmedicated baseline IOPs. So we had patients who were 25 or less, unmedicated, washed out, 25 to 30, and greater than 30. And we compared phaco to phaco with eye stent. This is based upon, again, the phase 3 inject trials. What you find is phaco maximizes its efficacy. Between 5.5 or so, or 5.8 is the max effect you get. Doesn't matter what IOP you start with, right? But look at the red, the eye stent. As you increase the baseline unmedicated IOP, you see a significantly greater reduction of IOP as you go along, which means you're increasing outflow facility. And that's the difference. And why is this so important? Because, yeah, at 30 or above, you see a pretty big difference. That's about a 4 or 5 millimeter mercury additional reduction with the eye stent. That's pretty real. But down below at 25 or less, a millimeter. So a lot of doctors say, what is a millimeter? Well, it's also the medication burden reduction, right? We don't wash our patients out. So patients on a PGA, here's an example. Patient comes into your office, they were 16 on a PGA, they have the eye stent cataract, and the pressure is 17 or 18 now. Well, is that really that much of a difference? Not really. In fact, they're better on the PGA, but guess what? They're off their medication. To me, I'd rather take a point higher even post eye stent, being off the PGA, not worrying about fluctuating IOPs, compliance issues as well. So I think the definition of success for me for any MIGS is not just IOP reduction, it's also medication burden reduction and stability of that IOP over time as well. But this was a great study that showed us that, yes, we are doing something more than just the cataract surgery alone. Another study that just got published, I'm proud of this one too. I was a lead investigator for this one with Tom Samuelson in Minneapolis. Showed us that, looking also at the phase 3 trials, that we now can prove that we are improving quality of life. What we did is we looked at VFQ-25 as well as OSDI questionnaires and patient-reported outcome responders, those who had an increase in their reported outcomes of quality of life. And we compared phaco alone versus cataract iStent, of course, in the study. And what you're going to find here is based on OSD eyes and VFQ-25, more patients had an improvement in their quality of life in the iStent group versus the cataract surgery alone group. And in the patients who had medication-free, higher proportion of those patients actually had an improvement in quality of life. So it was tied to medication reduction. And so looking at it even more in detail with the VFQ-25, you can see that patients in the orange, which is the iStent group, had more improvement in general vision, ocular pain, but also like things like driving significantly better as well. And part of this we think is because of the drop burden reduction as well. So now we can tell our patients truly that we do have data, large multi-center randomized controlled trial that says that yes, with the cataract and the stent, we have a better chance of improving our quality of life than with cataract surgery alone. I think this is something that's important, especially for the comprehensive cataract refractive surgeons who are like, I don't really think MIGS is that really big a deal. I'm just gonna do cataract surgery alone. These little things can make a difference as well. We talk about kind of quality of life post-operatively, even if the patient's pressures are only 1 or 2 millimeter mercury better or not even much better. That is another part of the, I think, story that we have to tell to get that adoption of MIGS a little higher. Hydrus has some great data too. I'm going to talk to you about. I love the Hydrus. This is again a stent that scaffolds the Schlemm's canal, and part of the inlet is in the here. You see with the arrow is in the anterior chamber, bypassing trabecular meshwork. And so this stent, you hear a lot of noise out there. Oh, it's a longer stent, it's harder, more difficult, more dangerous. It is not. And I really will tell you, I think, in fact, this actually probably has the least amount of actual manipulations in the eye out of all of our MIGS procedures. So I make a small extra paracentesis because there's a curved tip to the loader. So I'm gonna follow the curvature of the eye. I have a good view. That wasn't the best view there. So I'm gonna rotate the eye some more to get a little better view again, get that en face view where the trabecular meshwork is pointing at me. There you go. I see a nice beautiful TM facing me. Now I'm gonna go ahead and just show you a comparative between before I turned it more and the right. Even if that on the left, you see a good TM there, but it's kind of pointing down. I want it to point at me. So there's the Hydrus loader, little curved tip to it. I'm going to go through that small paracentesis that I made. Again, this is also only approved at the time of cataract surgery, but I'm just going to engage the TM. I'm not going to really score it or push too hard. I'm just going to keep constant pressure. I'm just going to go ahead. I was just teaching someone in the OR here, so you can hear me just kind of talking. And I'm just going to go ahead and advance this thing. Now I'm just going to push against the TM, about a 50-degree angle upward, and then just go ahead and roll the wheel and release the stent into the Schlemm's canal. It automatically opens up, and that's the real-time unedited version. And I think that's what I like about it. It's not a lot of hand manipulation. You don't have to go 2 clock hours away. There's no pushing against the eye, just constant pressure. And although it's longer, it's kind of cool because it actually scaffolds. You can see how the blanching is really in the distribution of the stent in the Schlemm's canal there. So again, a very, very, I think, efficient surgery, but also, again, mechanism of action. It helps scaffold that canal where we do know that some of those patients are completely herniated and collapsed, as I was mentioning earlier as well. That's one of the benefits. And here's another video just real quick. Again, showing you, I'm just going to go ahead and engage here the TM, keep constant pressure. Just advance this wheel, and then it just opens up like a clamshell, and then just remove it, and that's it, and we're done. So again, these are great, I think, advances as well with stenting. It shows us that these stents are very efficient, but yet can also mechanistically help our glaucoma patients. And so what's important is this idea of medication washout. iStent also shows very similar issues as well, but here, 48 months outcome, 4 years and 5-year data, showing us again, still a significant delta. More percentage of patients at 48 months were off of glaucoma drops in the Hydrus than in the cataract alone group as well. This is really important because when we tell our patients the benefit, it's not just IOP, it's medication burden reduction. In fact, based upon Marketscope data, in 2017, about 50% of our glaucoma patients around the country are being treated with one medication. 50% have 2 or more. And if you look at the Horizon trial, the phase 3 trials for the Hydrus, it emulated that breakdown very, very, very well, actually. And in that group of patients, if we look at on the right, the percentage of one med patients who are off of medication. So in the study, they came in with one medication. After 4 years, 71% of them were still off that medication versus 45% were off in cataract surgery. So number one, it's better than cataract. But number two is you can tell your patients, guess what? 70% chance you'll be off of medications at 4 years if you're on one medication. So it's a nice way to kind of help manage that expectation. This to me is probably the most important slide that we can share right now about these stents. And this is the Horizon trial, again, the Hydrus. This is at 5 years out, showing us between the Hydrus, which is in the blue here, down to 2.5, and the cataract surgery alone group, a huge difference, actually a significant 4% difference in the amount of patients who progressed to needing incisional surgery like a traberet tube. This is important because this is the first time we can actually share that these MIGS procedures are preventing further progression, needing incisional surgery. And what's more fascinating about this, which I think is really important, is that, sorry, here we go. About 2/3 of the patients who progressed to needing incisional surgery were mild to begin with, right? That's so important to talk about because we get so fooled, right? We say, they're mild glaucoma, pre-parametric on one med. Who cares about cataract surgery? Who about MIGS? Let's do a cataract, the pressure come down a couple of points, we're fine. Well, guess what happened? In these patients, 2/3 who progressed to needing incisional surgery were mild at the beginning. Within 5 years, progressed to become moderate, even severe in these cases. And this is why we can't be fooled. Just because they're mild today does not mean they're going to be mild in a year, 2, or even 4 years. And within 5 years, significant amount of patients actually progress to needing more surgery. So it just reminds us to not be so complacent as providers when we see patients with fluctuating pressures, not complying with medications, not taking the medications, brand versus generic medications, all those different issues we face, I think translate to that data set that you see there. Another question people have though with the hydrus, because it is longer in the Schlemm's canal, is what about the safety? Well, man, remember, it's mostly in the Schlemm's canal. Only a smaller portion of it is actually in the anterior chamber. And so it's parallel to, unlike the bypass that was coming out at you, right? And coming up almost parallel to the, or transitional to the TM. This one's parallel to the TM. And so it's not lying against the cornea at all. And if you look at ECD, endothelial cell density, or ECL, endothelial cell loss, there's no progression over time. If you're at 4 years, at 60 months, and 5 years, actually, we see a very similar effect. Here's another slide showing you the same thing. At but 5 years, we're seeing a stability of the endothelial cell loss compared to cataract surgery alone. This is important because in the COMPASS trial with CyPath, the superciliary stent that was removed from the market a few years ago, at 3 years, 4 years, you start to see a significant difference. It was really going down pretty rapidly. And that was based upon how long it was in the eye, of course. But we don't see that with the hydrus. And I think it's an important concept because people do get afraid of the fact that it's a longer stent as well. I'm going to fast forward for the sake of time. This is another hydrus case here, just showing you inferior loss in the nerve fiber layer in the right eye, corresponding to field loss in the right, which I think is always great. When you have field structure function correlation, it makes you feel so good as a doctor, right? You feel like, hey, I know what I'm doing. This is perfect. Everything's making sense. I said, let's go ahead. Did the hydrus with a toric lens. Again, patient has astigmatism. I'm a big fan of taking care of astigmatism. If you have a glaucoma, if you can maximize the quality of light entering the eye, more the better. And if you look at here, the pressure's middle teens, just like you expect with the stent. Quick visual acuity recovery. So to me, these stents are very good. And I tend to use a hydrus a lot too, especially if they're on multiple meds. You can use a hydrus with one med, not a problem. It's safe to use for mild to moderate patient, but I'll tend to use, especially if they're on 3 or 4 meds, I'll definitely tend to use the hydrus more because I think it's scaffolding the Schlemm's canal as well. Or I'll combine it with viscodilation, which is what I'm going to talk about next, because I think viscodilation is a very, very cool tool to use, not as a standalone only, which we'll talk about, but also as a combination to combine it with a stent, using the viscodilation to flush the canal, and then use the stents to bypass it or keep it scaffolded long term as well. The 2 most commonly used ones you see in the US is the iTrack catheter by Nova Eye and Omni surgical device by Sight Sciences. Both are, again, breaking herniations and releasing viscoelastic. Here's just a quick video. I know you guys already know all this, but just to kind of reiterate what's happening, you have a loader with the Omni, which kind of advances this catheter through the Schlemm's canal, 180 degrees. And once the wheel stops, it stops, you then retract the wheel back. And as you retract the wheel back, you're going to see here, you release viscoelastic. Now, the Omni releases about 5.5 microliters of viscoelastic per 180 degrees. So about 11 microliters total, which is not a huge amount. And the iTrack catheter, you'll see it in a second, when you can actually control how much viscoelastic you actually insert into the canal. So you can click a button, click a button, click a button, and you can actually tell the tech on the other hand to push more viscoelastic. So that's the benefit of the iTrack versus this one. You don't have that control, but it's nice because you can also do an otomy with this, and it's a little bit more efficient because this has a nice loader that allows you to do this procedure in a more efficient manner than the iTrack. So they both have their benefits and pitfalls. So that was the iTrack, the Omni device. And here's some surgical videos. On the left is the iTrack, which I'm going to show you here, which is a manually advancing this catheter. So here we are manually advancing this catheter into Schlemm's canal. And I'm just taking a microforceps here. Again, the view is key. I have a nice en face view. I'm advancing this catheter into Schlemm's canal. And I'm going to go ahead and go all the way around as much as I can. You don't have to go 360, but I go about 360 here. And you can see now it's coming around the other side. The red light is showing up now. I know that I've gone 360. And once I'm done there, I can come back out. And when I come back out here, I'm going to go ahead and you can see as I retract that catheter, I'm going to push viscoelastic on the other side. I'm telling it, click technician, click, 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 and there you go. And so now we're moving viscoelastic. On the right here is the Omni device, which again is a little bit more efficient. Here we have the loader, like I showed you in the schematic. You just engage the nasal angle. You just go ahead and just advance this catheter. And by advancing the catheter, it'll go into Schlemm's canal. And you don't have to worry about being in the eye and actually manually advancing it as well. The lights went off again in my room here. Sorry if I'm dark. But again, the idea here is you advance it, you can perform an otomy. So once you're done advancing it, you can retract it back and then re-advance it. And then you can perform an otomy if you want to as well. Let's see if I can, here you go to the other side here. Let's go to viscodilation there. And I'm just going to go ahead and make sure we have a good viscodilation. Sometimes it will come out the other side. So you have to reorient your hand to get that catheter to go in the stay in the canal. So that's a little bit of nuance with these devices, making sure that the canal and the catheter stays. And see a little otomy there? I ripped the TM a little bit there as well at the end. So sometimes I'll combine viscodilation and otomy with the Omni device as well. These are the two devices that we use. And what I want to show you something here is really cool. This is something that to me has been an eye candy. This is a huge development for me. For so long, a lot of people were naysayers with canaloplasty and said, hey, are we really viscodilating? What's really happening? Is the catheter doing all the work? Does pushing viscoelastic make a difference? Well, this is a real-time OCT. So I have a machine called the Artivo with Rescans, the Zeiss scope that has intraoperative OCT as well. And so we can see real-time what's happened to the angle. Now, if you look on the bottom right here where my hand is, this is the Schlemm's canal with the catheter already passed. So the catheter is already in the canal there and passed around this. And this on the left here, the square is where the scan is scanning right now. And so you're going to see in a second as the catheter comes around what happens. So on the bottom right is the actual canal. And you can see here as I just go ahead and show you, that's the canal there as I highlighted. And then as you see on the top left, there's going to be a catheter coming around. I'm going to pull the catheter back. I'm telling my technician, click, click, click. Now, as I get close to the box, look on the bottom right, what happens to the actual canal. As I click now, I'm clicking, 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 clicking here. Look what happens to the canal. It gets big and round. I'm not sure if you can see that through the web here, but it is so cool because real time now, we can see a not only enlargement, but also a stretching. You can see here, I'm just going to pause it. On the left here, you see the thickness of the trabeculometric right there. And on the right, you see how it's thinned out on the right? We are actually stretching the TM, stretching the canal as well. So that's what's kind of neat to finally be able to show real time what viscodilating is doing to the canal as well. So we are doing something more than just break-in herniations. We are stretching things open as well. So to be able to combine this with stenting, I think is a great opportunity as well. I'm going to show one more little video here real quick for the sake of time. This is kind of neat. This is just doing 180-degree viscodilation. So people ask me too, Paul, does viscodilation have any power to really improve outflow, or do we need to do a cutting with it? Well, here's an example of just doing 180. It's just did only 180-degree of viscodilation with the eye tract catheter here. What I want to show you, which is cool, is this. Now look down here at these vessels. As I'm removing viscoelastic with my irrigation aspiration, you're going to see these kind of fluid wave and these episcleral vessels. Look at that fluid wave there. It is so cool to see that. Now, what I'm going to show you in the 180 degrees that we did not do the superior here. So I'm going to go ahead and show you as I go now to this is inferiorly. Actually, let me go here superiorly here. Hold on. Sorry. There we go. Superiorly, you don't see any movement of flow. So just with 180 viscodilation, you can see that we're actually improving outflow in that area. So I think even 180 is a good option for a lot of our patients, let's say as well. Just going to fast forward here for the sake of time. Just showing you data on this as well. No doubt we have good data supporting that it gets you down to the middle teens. Like anything else, conventional outflow MIGs will get you to stay in that middle teen section. And the middle teens here, about a 60 to 70% reduction of meds, about a 15 to 20% reduction of IOP. So if your patients are on 3-4 meds, pressures in upper teens, you say, doc, if you say, hey, your target pressure is middle to upper teens, let's just try to get you off of some medications. The canaloplasty procedure can do a good job for you. You look at data with canaloplasty with a little otomy. This is the Omni device data, at the Romeo study, showing you're going to get down again to the lower to middle teens, 15 range. But again, less number of medications, significant burden reduction, about 70% reduction of medication burden. In a study that I'm part of as well, called the Gemini study, which is with cataract surgery and doing 360 viscodilation, 180-degree otomy, you also see, again, significant reduction of IOP down to the middle teens. But again, burden reduction of medication is significantly reduced. So down from 1.8 down to the less than 1 range here, about 0.4. So that's the key to success and the key to defining success with our patients. The medication burden reduction is so important when we define success for these patients. Again, lastly, with the cutting procedures, we have the GAT. We also have the hook dual blade or the other devices that we can think of, hook dual blade as well as another one come by MST now. MST has one as well on top left there. You can see that actually it has these serrations that allows you to also remove TM. I have found the one with the serration with MST here does kind of have more of a rough removal versus the hook blade is a little smoother, but you can see that nice white line down below. Again, as we're performing it, you can see how you see a nice white line. That's a posterior wall of Schlemm's canal. You've removed that trabecular meshwork, but you got to be careful. If you're not in the TM, if you go down, let's say below, if you're not understanding your anatomy, you can create a cleft on the bottom of that left white line there. That's actually a cleft that you created. So patients get hypotony if the cleft is too large. So you got to make sure you're staying within the canal when you're removing these TMs as well. And this is showing you again more data on the hook dual blade and trabectome. This is on the right is icon, and I don't use the trabectome, but on the left is one of my KDB patients, and it's the new something called a KDB glide. Again, just showing you again a nice smooth way of removing the TM all in one as well. So you can see a nice white line there. And I think it's a good option. Where do I use KDB? I use KDB a lot of times when they're pseudophakic. They had, let's say, a history of enclosure, let's say PAS, where I think the TM is thick, let's say pigmentary glaucoma. I'll try to remove a nice strip of TM there. And I think I'll get good efficacy with that as well. So really, I don't do it more in phakic patients, especially if they're younger, because I want to save that trabecular meshwork when they, let's say, need a stent or something that's long-term later on. So if they're younger and healthier, I'll tend to do more viscodilating procedures. If they're, say, had a cataract surgery already, had pseudophakia, or they had PAS, I'll definitely think it's really nice to use that KDB to be able to remove that TM as well. Sometimes if they have insurance issues, stents aren't approved sometimes, the goniotomy codes are more covered. So for some patients like that, like on the left there, I did a KDB on a patient who's cataract because the patient didn't have stent coverage in their medical coverage as well. So different factors, of course, that decide what procedure we're going to use as well. Again, long story short, with these procedures like the other ones, you're going to get in that 14, 15 range. You're going to see a consistent theme. We're getting the middle teens on less medications. That's a very common outcome that we're going to find with any of these conventional outflow MIGS procedures. And that's kind of what I tell doctors all the time. It doesn't matter what you do. You're going to get that middle teens. It's what you're most comfortable with. What's the anatomy of the eye? What's the pathophysiology as well? Just looking here between KDB standalone and KDB with phaco, no doubt phaco does give you an extra reduction of medication or so, by 0.8, but both do get, even as a standalone with KDB, gets you off some of those medications. That's another rationale to do MIGS, is even if they're stable with their IOP, get them off of 1 or 2 meds. You can do that with a lot of these different procedures. And last, I want to talk about the Zen. I'm not sure if any of you are co-managing Zen a lot or have colleagues in your area that are doing a lot of Zens. I think we tend to place this in the wrong time. This is not meant to be a trab killer. You're still going to do trabs. But what this is great for those patients, let's say what had a KDB, had an Omni, had an iStent, and are on, let's say, 3 meds, more moderate glaucoma, where you're kind of saying, well, they're not bad enough to have a trabeculectomy, but I don't really want to do it. I don't think they're really happy with drops. Perfect to do a Zen. Zen's going to get you on that lower to middle teens also, 13, 14 range very commonly. But the reduction of medication burden is incredible. And if you look here, even in the IDE trials that they had, their 510K trial, they had patients who had refractory glaucoma, previous glaucoma surgery. They were still getting 9 mm mercury reduction of IOP down with half the number of medication burden. And again, patients down to low teens as well. So we're going to get there. And what makes Zen so unique is the fact that it actually has a number of, different type of ways of doing the surgery. My preferred technique, and you can do the ab interno on the top left. Top right is a transconjunctival approach, and the bottom is a cut down. What I think is the reason why you hear bad things about the Zen, if you ever do hear it, is because they say, oh, we have to bleb needle it. It scars down. It is true. Sometimes you have to do a loosening of scar tissue or of the tenons, which can cover the stent. It's only a 45 micron lumen. It's a 6 mm stent that can very easily get blocked if you have tenons. But if you do it from an external on the bottom where you're removing conj or opening conj, placing the stent, then you can place the conjunctiva and tenons over that stent, and you can clearly know where the tenons is in relation to the stent. With this technique on the bottom here, with this conjunctival technique here, where I place the stent, now I'm just going to go ahead and just tuck the tissue, the conjunctiva, over that stent and close the tenons and the conjunctiva over the stent. I'm making sure that that T9 is not going to retract back and cause fibrosis as well. So with just a couple of wing sutures here, you can go ahead and close this tissue up very quickly. It's a very efficient 5 to 10 minute procedure, even with a cut down, and you're able to really get these pressures down. And I'm getting down to low 10, 12, 13 range off of medications a lot of times. So again, healthy conjunctiva is important. I think this cut down technique decreases the amount of times that we have to cut or bleb needle, sometimes loosen up scar tissue postoperatively. But with this technique, I think having external cut down allows me more accuracy of knowing where the T9 is in relation to the stent. This is just a gonioscopic view showing that stent in the superior angle there, coming at the level of the trabecular meshwork. Now, one thing is important is mitomycin still used. I do see injecting about 0.1 cc's of 0.4 milligrams per cc of mitomycin, so 40 micrograms of mito. I think in the studies that were done, only 20 cc or 20 micrograms were used. Some people, my colleagues on the East Coast, are using 60, 80 micrograms. You just got to be careful to keep that MMC, the mitomycin, away from the limbus, because you can get ischemia and you can get stem cell deficiency if you let the mitomycin migrate too far forward. But I think the Zen is a great opportunity to really get those pressures down, especially as patients have already had MIGs and you don't want to do a trab-on. I think it's a great opportunity as well. And what's cool is that using intraoperative OCT, as I mentioned earlier with the viscodilating procedures, the canaloplasty, here I'm showing you here, nice mobile conj. This is I'm doing an ab interno approach here. And you can see the Zen is beautifully mobile under the conjunctiva, no T9s collapse around it, nothing kind of scarring down, which is good. So I like to know intraoperatively that the stent is moving and not stuck in anything. But I'm going to show you here how I'm going to use OCT. And this is cool. I'm using intraoperative OCT to see where that stent is in relation to the tissues. You can see here with that arrow, that is the stent. This is a cross section, right? OCT. There's a stent. And this is the T9s right here. I'm above T9's capsule, that little white line there, and I'm below the conjunctiva there. So I'm in this space here, which is really kind of cool to see. And so you can actually see where you are in relation to different tissues, which you couldn't do before we had intraoperative OCT. So it's kind of nice to have this ability intraoperatively to know where you are and to kind of confirm with OCT as well. So we're kind of using that now technology more with our MIGS procedures to help know where we are as well.
Fairly quiet. Now,
one more thing I'll tell you is how to combine these different procedures. We can combine things like drug delivery and let's say something like a Zen. So here's an example of a patient who had really bad hyperemic eyes. So I used a Zen, did the Diamox, took them off the medications, got the conjunctiva ready. Now the conjunctiva is really healthy. And I'm doing my Zen here. What I'm going to show you here is I'm doing my Zen. I'm sure there's a Zen outside the eye, measuring it. You can see the Zen internally. There's a Zen internally. I'm going to show you though, I'm also going to show you a Durista. So I did a Zen, but about a month beforehand, I did a Durista. And you can see here a nice Durista on the bottom there. That's the Durista sitting there. So that Durista was planted about a month before surgery, before I did my Zen, to get them off the topical PGA. And that will stay there even after my Zen. And I haven't found to be any negative having that Durista inferiorly, even with my Zen. So I'm combining these different technologies to help maximize outcomes. In this case, getting them off the topical drops before surgery to help maximize the health of the conjunctiva so it doesn't scar as well. Just going to fast forward here for the sake of time. How are we doing with time here? Do I have, is it 1:12? How are we doing with time, Murray?
Yeah, no, Paul, you're doing fine. I mean, if you want to go about another 20 or so minutes.
Perfect.
And then we'll take any questions. If that's
okay. Good. Yeah, I'm sorry I'm rapid firing here. We have so much content. I'm like, but I'm gonna try to fast forward through some of these just so we can save on time. With the bottom line with this case here, I want to show you that a lot of our patients who are, let's say, stable. This is a patient who's baseline, and 3 years later, fields don't look that much worse. Maybe a little bit MD down from -4 to -5, but not a significant change over 3 years on their fields. If you look at their OCT, fairly stable. Now, yes, they have inferior loss of a nerve fiber layer, corresponding superior loss on the fields, but guess what? It's pretty stable for the most part. Not a significant difference over 3 years. But this is a patient who's on 4 medications and not happy with taking meds. Perfect Zen case. So I went ahead and did the Zen. Beautiful, nice bleb there, diffuse, low lying. You can see the stent in the subconch space there, right there as well. So on pressures 12 on no medications, especially the older patients, Caucasian, who have thinner conj, they do great with these. They tend to have less chance of scarring or bleb needling, and they get those pressures can be down to 10, 12 range oftentimes with the Zen as well. I just don't want us to forget about ECP, because ECP is something that we used to do a lot of. It's probably the first MIGS procedure done. And it is overall pretty innocuous. It doesn't cause a lot of inflammation. We do give some Decadron or some dexamethasone at the time of surgery to calm any inflammation. But unlike transscleral, where you're really blowing a hole into the ciliary body, here we're targeting the ciliary processes intraoperatively. So we're seeing less inflammation than you'd see transscleral. And the key is just to make sure we whiten those processes. One of the reasons why there's variability of effect with ECP is because the surgeons sometimes are not painting those processes and getting them to shrink up like that. And so it happens to go pretty fast. And when they go pretty fast, they don't kind of go back to see, do they really shrink them up? You have skip areas. If you have any skip areas, you're still getting enough flow, enough production of aqueous where they may not get the significant reduction of IOP. So you really got to be thorough and diligent about shrinking these processes and going back, really painting them back again and again, really making sure you didn't have any skip areas. But the ECP is a very I think, efficient surgery. It's, I think, user-friendly, and it works well with even other MIGS procedures that are helping outflow. This is just a long-term data with ECP alone, showing, again, similar effect down to the 13, 14 range on less medications. And with iStent showing additional reduction of pressure here, about 1 millimeter or so, additional 1.5 millimeters, again, with a little bit more reduction of meds. And so I think it's a great opportunity for us to combine still, even though we don't do a lot of combination with ECP. I think going back now and combining ECP with stenting and even viscodilation for those more moderate or severe patients is a good opportunity as well. I wanted to briefly talk about a few different topics before we go on stuff that you don't have right now that we will have soon. I'm part of a couple studies. I was part of the super study, which is, again, these are supraciliary stents like the CyPass. The CyPass was taken off the market a few years ago because of endothelial cell loss, but there's other companies working on stuff. And this is one called a MiniJect. The MiniJect is a device here that's 5 millimeters in length that has a porous material, like a silicone material. It's flexible. And it also has a green marker to know exactly where in the anterior chamber you want to leave it. There's about 0.5 millimeter in the anterior chamber, which is like about less than 1 ring on the CyPass. If you look at the CyPass data, if you had more than 1 ring, that's when you started getting cell loss. 1 ring or less, there was insignificant cell loss with the CyPass. So the same thing here, we have about 0.5 millimeter in the AC, but it's a soft, porous material that is not as flexible, that is more flexible, unlike the CyPass, that was more of a rigid stent, polyamide stent. And if you look here, that's what it looks like there, kind of a nice wheel that advances it. I'm gonna show you one of my first videos here. Let me see, this is a schematic showing you how we implant it into the supraciliary space. Again, the supraciliary space, the benefit is it's a negative pressure gradient. We're not relying on the conventional pathway where the resistance to outflow is. So whether it's a TM or Schlemm's canal or distal channels, who cares? You're going to go ahead to the supraciliary space. So people who've already had previous MIGS, conventional MIGS, people have bad conjunctiva where you don't want to do a TRAB or tube or even a Zen, having this opportunity would be great for a lot of these patients. And I'll show you one of my first cases here where I was kind of nervous. I'm pushing forward here. I'm just going to fast forward this here. Unedited. I'm advancing this here. I'm going to release it. And you can see as I release it, there you go. There's that little blue or green little line showing you where it is in relation to the scleral spur. And so we're seeing it, again, far away from the endothelium here, and it's allowing us to bypass fluid into the supraciliary space. And they have great data coming out. We're in the phase 3 trials right now with that. Another stent that's being worked on right now in the phase 1-2 trials is this here, which is the used to be called the micro shunt to micro optics micro shunt, the brown shunt. This is in Minnesota, Dr. Reidel's first case here, and it's showing us this is a shunt that goes into the anterior chamber, but it bypasses fluid not under the conjunctiva, but at the limbus into the tear film. It has a one-way valve. So from an ease of implantation, we're talking extremely easy. I think most comprehensive surgeons who don't do glaucoma would feel very comfortable going ahead and just inserting this into the anterior chamber. You just insert it and you're done. There's no cutting of this conj, no closure of the conjunctiva, there's no PIs, nothing. And it's just diverse fluid into the basic tear film. It's a one-way valve. So far, they had not seen any endophthalmitis patients or any risk of infection so far. But what they have found, unfortunately, is some blockage. Mucus and tear film debris can block it. So that's a negative thing they're trying to work on. But overall, that's so far from a safety perspective, showing high safety as well. So when we decide on what's the best option, right? I kind of went through a lot of different topics pretty fast. To me, it's about an angle anatomy. It's about disease severity. The more severe the disease, the more I'm going to combine mechanisms, as I'll explain in a second here. And also maybe do things like a subconj surgery. I'll go right to subconj because the fact that severity might be higher or the target pressure is lower. But a lot of it has to do with the post-op course and the surgeon comfort level. Some surgeons just aren't comfortable with certain procedures, and that's why you're seeing people sticking with 1 or 2 devices. We're trying to help open surgeons up, kind of like multifocal lenses versus, let's say, extended depth of focus lenses versus standard torics. We have options depending on the patient anatomy. The same thing as well. And I want to just briefly, the last 10 minutes, talk about my excitement, which is combining MIGS. I think I'm a DJ, so I go, I like to remix a little bit of some viscodilation with a little bit of some stenting. And I think mixing is great. We talked about the ECP and iStent. We've done it for so long. Some things don't mix well, like this, but when you have a nice, oh man, McDonald's apple pie with their sundaes and their vanilla ice cream, oh man, I could eat it all day long. It's awesome. So for me, mixing ECP and stenting, we've talked about, has worked very well, but I'm doing a lot more of this now, viscodilation and things like the hydrus. Here's an example of doing viscodilation with the Omni device, and then going ahead and putting a stent as well. So I'm gonna go ahead and viscodilate. I'm going one direction with the Omni right here. This is a patient during COVID on 4 meds, pressure in the low 30s. So I was being really as much as I could, as aggressive as I could, in the safest way possible, because the patient couldn't follow up very well. So I did an Omni, 360-degree viscodilation. Again, I'm advancing this catheter into the Schlemm's canal. I'm gonna go ahead then and retract it back to release viscoelastic. I'm gonna re-advance it, right? I'm gonna re-advance it, and now I'm gonna go ahead and perform an otomy. So just a little bit of some tearing of the TM, cutting the TM. Now I'm gonna go back in and put my hydrus as well. So I went ahead and did 360-degree viscodilation, 180-degree otomy, or close to that. And now I'm gonna go ahead and put my hydrus stent to scaffold that one area there, and also maintain it long-term and bypass TM. So I went ahead and maximized as much as I could the conventional pathway in the safest way possible. This patient's pressure is around 16 to 18 range. Remember, she was 34 on like 4 meds. 16 to 18 off of medications. And what I found when we look at our data, I'm just going to fast forward here for the sake of time. Here's just the eye catheter with iStents and hydrus. What I found with our data is this. Now, this is our first data we presented a couple of years ago at ASCRS. And again, it's a small pilot study, only 24 eyes, only 6 months of follow-up. So take that for what it's worth. This was presented at ASCRS in 2019. And we found that we got pressure down to, guess what? The middle teens, 14 to 15 range, which is what you'd expect. But the drop burden reduction was significant. We were able to get patients on a lot less drops. In fact, here, 2.4 meds down to only 1 patient needing a PGA at 6 months. So the medication burden reduction is something that, to me, was where I found a significant benefit. So when I look at my algorithm, this is something I tell docs, if they want to take a picture or email me, I can send it to them. This is my conceptual algorithm of how I combine viscodilating and stenting and cutting, and how I do them all, depending if they have a cataract, if they don't have a cataract, how severe they are, the more number of medications they are, the more I'll combine viscodilating and otomy, versus if they're more mild on basically 1 or 2 meds, I might just do a stent at the time of cataract surgery. Or if they're, let's say, phakic, I'll do viscodilation alone if they're on 1 or 2 meds. Or if they're on more meds or more severe, then I'll do some otomy with it as well. So again, this is kind of my conceptual algorithm in my mind of how do I segregate and separate all these different devices, and the concept of combining viscodilation and stenting as well. So if you guys ever want this, just email me and I can send that to you as well. I also think, though, what's also been fun is being able to combine drug delivery in the post-op course with these things. This is something called the Dextenza. I do also DexaQ, which is an intracameral dexamethasone. This is an intracanalicular insert of dexamethasone to help decrease post-operative drop. So for a lot of my patients who are on, let's say, cataract MIGS, I'll put this little pellet here, this little canalicular implant that releases dexamethasone over 3 to 4 weeks to decrease the drop burden. And we have not seen a spike. In fact, we presented a paper at ASCRS this year looking at patients who are having cataract combination with MIGS, with and without Dextenza, no difference in safety or efficacy in terms of spikes of pressure. So I do that, and even DexaQ, which is intracameral, a lot. So if I can get people off of medications even after cataract surgery with steroid words, I've definitely find helpful for my patient satisfaction as well. And the last couple things here, guys, I know I'm going fast, but last couple things here I think is really exciting is our ability to then, again, really understand which patients are benefiting and what's happened to the episcleral outflow system. This is a kind of a cool little technology here called the Plex Elite by Zeiss. We're part of a study looking at pre and post MIGS and scanning with OCT angiography and swept source OCT, the preoperative episclera, the conjunctiva, and the libus. And we're looking at pre and post architectural vessel changes. And what we're trying to look at with AI eventually, now you need a lot of N for this, but looking at AI, can we see pre and post? Are there certain eyes with certain actual architecture or their vessels that can help us determine which patients might benefit more from any certain MIGS procedure? So if you look on the left, this is pre. On the left here with my arrow here, this is an iStent case. And then on the right here is a post iStent case as well. And you can see a more dense vasculature here and you do here on the left. Now, what does that mean? You're going to ask me, Paul, what do you think? What does that mean? We have no idea yet. So this is more of a conceptual thing, but I want to kind of mention to you, there's me and a couple others working on this just to get the data to see, does it help us understand what's happening to these eyes over time? And can we kind of go back then, look at efficacy and kind of correlate the architectural change or the preoperative changes as well. Another advancement you're going to see now is understanding our ability to understand IOP outside the office measurements. Here's something called the iMate, which is an intracameral device that goes into the bag that allows us to measure IOP with a sensor 24 hours a day. And on the right is something called Triggerfish, which is a contact lens, and they're working on some newer versions of it, which is basically looking at volumetric changes of the cornea, which is a surrogate for IOP changes. So I think more data, more understanding on a 24-hour IOP will give us a better understanding which patients might benefit or which patients might be progressing as well. And the last thing here is something called Equinox by my friend John Berdal. This is a non-surgical procedure, I know, but this is something that I think is really kind of cool, because if you think about it, we can't really control nocturnal IOP. We can't really control pressure directly a lot of times as much as we want to. But with this goggle, we can actually allow ourselves to actually dial in how much IOP reduction we want and actually help improve blood flow, especially at nighttime. Because remember, we're all pressurized. We have gravity pressure on our eyes. If we can put a goggle that has negative pressure, we can change the blood flow and help the blood flow gradient with the lamina curvosa. And you can actually dial in IOP reduction with these goggles down, if you want, even down to the middle single digits if you want as well, with the more suction you have on these goggles. And what's cool about this as well is it can give us IOPs that are more stable at nighttime to flatten out that curve, kind of like a trabeculectomy. So you do drops, etc. in the daytime, at nighttime, put this goggle, keep that curve flat. So in a nutshell, I think to close us out, we have a lot to think about, a lot to learn, but we have a lot of options now that can tailor our treatments to our patient. Earlier the adoption, better, less chance we have of progression over time based upon larger studies that we've seen. I think combining mechanisms, learn to utilize multiple technologies can allow us to, again, halt these patients early on when the target pressures are higher, so we don't have to be as aggressive getting them down to that 10, 12 range as well. So I think it's an exciting time, and I want to leave us here with a few minutes so we can talk more about some questions you guys had as well.
Nah, Paul, that's great. I mean, all these amazing, interesting, technologies are just changing things around. Right before we get into questions, and we welcome any questions. Please just use the chat function. There was a request, if possible, if you'd be able to share some of your slides. Would there be something that you can that we can get from you that people would have as a kind of a handout?
Yeah, sure. What I'll do, Murray, is I'll email you, since I have your email address. I'll email you the whole presentation, even with the videos. Then you can decide. You can disseminate the videos if you want, or even just put
Yeah, we can put it online and make it available. Thank you.
Perfect. Let's do that. Sorry, I was putting the lights back on.
Yeah.
Sorry about that.
Hey,
There you go.
So Paul, that's like our encyclopedia right now for all of us educators to share with our students and our residents, because you covered everything so eloquently and in such detail and with such clinical insight. And so I really appreciate you providing this for us today. And, as you can tell, there's a lot of optometric educators for this program in particular. And, we are struggling a little bit with how much content and how much MIGS talk to give to our optometry students in a very quickly changing landscape. And of course, we're trying to make sure that our graduates and our residents can really co-manage and interact with cataract and glaucoma surgeons. Do you have any insights as to, we can't perhaps present all this material to our students, as you can appreciate, hopefully, highlight, where educators in optometric programs should focus their attention for their students and residents?
Well, I think, it's a great question. I think we are seeing more co-managing. I think I look in our practice, our optometrists are our first line. They do all the medical stuff. So I think you're going to see more and more practice. I'm a big fan of working with optometrists, very well.
Yep.
And so I think it's important to know, for me, it's a post-op management that's really important, right? That's because that's where I think the skill set of the optometrist is going to be utilized. Because if you're seeing them post-op management, to feel comfortable knowing in how to deal with hyphemas if that happens, right? and how to deal with, let's say, do we do more steroids? For instance, a lot of these, I didn't get a chance to talk about it, and I probably should have, was talking about when you do a cutting procedure, let's say, where you get, let's say, get hyphema postoperatively, it's not
Right.
necessarily where you have to increase steroids, because actually it's not bleeding. So if you look at, like, let's say, a canaloplasty or even iStent, and you get all this, let's say, hyphema for some reason. Well, if that's the case, it's not bleeding, it's a reflux of blood. And so reflux of blood does not mean inflammation. So sometimes I'll just keep the same amount of steroids, but sometimes for those patients, so they may get chronic hyphemas, giving something like pilocarpine has helped in those patients as well. So I think being able to know how to manage those, knowing, is it inflammatory, like a Zen, knowing, is it something that we have to do more steroid use, and looking at the blood morphology. So let's say you do a co-manage a Zen patient here, and let's say with the first day or so the pressure's up, that means this might be some physical blockage. If at a week or two out, you see a nice bleb, but it's cystic, that means there might be some fibrosis there, put them on aqueous suppressants. Or let's say a month and a half out, the bleb is flat, they may need a needling. And so these are the kind of technology, these are kind of, I think, pearls that we have to, and I probably didn't go there, which I probably should have for today, but really talk about how to manage those post-operative kind of outcomes. I think that from a pre-operative perspective, if you're working with a surgeon where you're kind of sending them all these opportunities, telling a patient ahead of time, it helps a surgeon a lot when look,
Right.
I get a lot of referrals from optometrists, and they trust, look, I look at myself as helping my optometry colleague, that's their patient. So the optometric referral is, that's the patient who's the optometric patient. So I tell a patient, look, your doctor trusted me to help you out. I'm gonna send you right back to your doctor there. So they can help educate on the front end, saying, look, there's a number of different solutions that the doctor so-and-so will have to do surgery on you. We don't know where your resistance is, but he's going to recommend something. If hypothetically it doesn't get the pressures down, we have other options. They have other options as well. We can go back to drops. So that education, that expectation building of what is the definition of success, meaning telling a patient, look, you have 3 medications. Dr. So-and-so may do a procedure like a stent, let's say, to get that pressure down. Your pressures may come down, but you may still have to be on 1 drop potentially. The data shows about 70% of people are off of 1 medication if they're on 1. So 30% have to go back on meds. So don't worry, but hopefully we can get you off those meds. And if not, the pressure may stay more stable at least. So having that pre-operative discussion, that expectation building, helps the surgeon, but also helps you when you get back that patient over time.
Great, great. I think a follow-up talk for sometime in the future would be taking a deeper dive on the post-op stuff.
That's a good point. Thank you for telling me that, because I just realized now, from your perspective as optometrist, that's where you're going to see the patient, and your skill set is going to be utilized more on the back end more than this. That's a good point.
And it's, some of us have that, but not all of us, and having greater insight where we could package it so that the general optometrist, who's doing, whether it's a Hydrus, iStent, Duristafol, whatever it is, they often don't know specifically what they should be doing. And so as educators, we're often charged with like, okay, we got to make this sort of a little bit cookbook for our graduates and our residents. That's
a great point. In fact, maybe what we could do in the future, if you want, we could do it now that we have the pre-op and the introduction to all these different devices.
Yep.
Okay, let's go through the post. How do you manage post-op SLT spikes? How do you manage post-op Durista? When do you put them back on drops? When is the efficacy wearing off? How do you know? Those are great points as well. So I'd love to do something like that for you guys.
I think you'd be great for that.
Yeah.
Thank you so much.
So Paul, maybe we'll come back and see if we could set that up for the future. That's great. So, Paul, I was fascinated on your slide that showed that there is on the cataract and the refractive and general surgeons, the uptake was somewhat not flat but slight, and on the glaucoma specialist it's flat. That the glaucoma specialist and MIGS doesn't surprise me, but even with this, the slight uptake, clearly that the amount spent by the insurers year to year to year is going up and up and up, and it's freaked at least the Medicare payers out enough that they've recently recommended a significant reimbursement cut. So I can't see that happening, and many optometrists, many of us have sent in letters in support of trying to change this around. But it appears that given these days that that the pool of money for example, glaucoma surgeries or ophthalmic surgeries is not increasing all that fast, if at all. Something's, what do you see? it just seems that is MIGS just going to take over the space? I mean, it's that, you know, it's just coming to a head quicker than anybody thought. I mean, or is this, you know, I mean, clearly something got to happen because the pool of money is not, you know, has not increased in years.
No, it's a great question, a great point. So there's a lot of data right now looking at cost analysis, and what Medicare is not taking into consideration. So when they did their analysis, their committee to kind of value the iStent, let's say for instance, Hydrus and iStent for their new code, they're going to be a level 1 code now versus a T code.
Yeah.
And then when they did that, they kind of placed the value purely on time. You know what they did, and this is kind of they surveyed doctors how much time, and it's the problem with ophthalmologists. And I'm going to sell myself out. We love to show off. We're a bunch of idiots because we say, look how fast we are. We're so quick. 5-minute cataracts. My iStent takes me 10 seconds, right? So what does Medicare say? Ding, 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 ding. Guess what? So they actually looked at videos and they actually said, okay, they looked at time it took to go in and time it to come out. Not the time it took to turn the head, to get the good view, all the skill set, pre-op and post-op, all that stuff. No, nothing. And so they said, oh, it takes about 30 seconds or a minute to do. Great. Here's how much it's going to cost you. We'll give you $34 now, right? Now, and here's how flawed this system was. And when you looked at the data, and when they came out with their recommendations, when they said the timing, they came out and claimed that when they looked at data and looked at surveys, it was faster to do a cataract stent than it was to do a cataract alone. And that's medically impossible, right? That's impossible, but that's how flawed their data was. So they do know, and there's been a lot of fighting going on back and forth and a lot of submissions, and thank you from the optometric community as well. The need, it's going to go back up. It won't go back up to the level that we thought, like in $400, $500, $600, $700. It might be like $100 or so, 150, which I think is still more palatable for some doctors. 34 is just embarrassing, really. It really is to see. That's the benefit we're giving to helping patients in long term. But to your other point about cost and how much money we have in the system, what you're seeing now also is companies like Glaucoma and Ivantis and New World and others doing more cost analysis, looking at how much these patients are off the drops, looking back at the phase 3 trials, looking at costs and seeing how much they can save industry. Like you look at the UK with SLT. The UK saved hundreds and hundreds of pounds every year on drops, and there's less need for incisional surgery in general. So if we can show that to Medicare, saying yes, and the front end, it's going to cost you an extra $1,000 or $2,000 more, but in the lifespan of this patient, you're going to save yourself $10,000 for X, Y, and Z reasons. That's going to be needed to show insurances and show Medicare that yes, there's not a amount of money to spend, but spend it now and save it later on everything else. So you're going to need that as well over time. What you're going to see in the short term, though, everybody, you're going to see your co-managing docs doing surgery, you're going to see a lot more viscodilation. The reason I brought up the combination is you're going to see a lot of Omnis going, and a lot of Omnis or a lot of KDVs, but a lot of Omnis with the iStent. Because guess what? Omni or viscodilation canaloplasty pays about $800, right? And iStent's going to pay $34. So guess what you're going to see a lot of. So just be aware and be prepared to see a lot more of that. I believe in it. I think there's a good mechanism, right? Break the herniations, flush it out, put the stents in, makes sense. But you're going to see those doctors who didn't do that adopting that philosophy because of financially it does make more sense.
Yeah.
I hope the companies do that research and give that, financial information and lower costs in the long run to CMS and Medicare.
We need that. And the companies know that. They're actually designing new studies with that in mind, because without that, it is hard to convince Medicare. Yeah, it's great. Patients are happy. They don't care if patients are happy. They can give a crap. In fact, I'll tell you a true story. This is how. Okay, so I was. I'm gonna try to make it a quick story here. There was a company that asked me to invest in them. So it's an orthopedic called Roundtech. It's an orthopedic company. Long story. This guy was telling me about his reactions or his communications with Humana, and Humana was telling him, look, we don't give a shit. We don't care about anything to do with patients. We don't care how much patients are happy, how quick a recovery is. We care about money. So how much can you save us? That's all. And he was telling me that's what they care about. So it was just really to have an insight into what insurances care about. They don't care about what we care about, right? So the bottom line to your point, Michael, is we gotta make sure we show them, here's the value add. Here's how you're gonna save yourself money. Without that, It's gonna be hard. You're right.
Yeah, no, it's a great point that, I mean, we all know the medications down the road are declining. And it's, and what's interesting then is that you start pitting one part of the glaucoma industry, i.e. the device makers, the surgical device makers, against the pharmaceutical companies, and so it is extremely complex. And I'm just looking, I don't see any more questions. Rich, John, anything to add? Anybody online have any questions? If not, we'll be stopping and then allow Dr. Singh to go back to his other meeting. And I don't see anything else. So, Paul, thank you very much. To take the time today. your talk was great. Really, have taught everybody just so much. So, thank you very much.
My pleasure.
Same here, Paul. Really, really appreciate it.
My pleasure, guys. Be safe.